Hello and welcome to Chapter 13. Today we'll be discussing altered hormonal and metabolic regulation. So this is all about hormones, and we'll be discussing several different characteristics of hormones. There's control of the hypothalamic pituitary axis, which is where most of our hormones are derived from. We have different feedback mechanisms that characterize our hormones, and that includes positive feedback and negative feedback. We have different patterns of hormone secretion, which includes metabolism and elimination. We also have receptor binding as well as action on target organs and glands. The first thing we need to know is that the hypothalamic pituitary axis regulates the release of hormones. So this is where a majority of our hormones are stimulated from. And as this picture shows, it works on different organs and areas of the body. So we have hormones that go to our kidneys, that go to our breast and uterus. We have hormones that go to our bones and the thyroid gland, testes, ovaries, all kinds of areas within the body. This is heavily regulated by the hypothalamic pituitary axis. What happens is that the external stimuli or internal stimuli, they stimulate the hypothalamus with these neurotransmitters, and they do release the hormones. And that could be a variety of hormones. That could be thyrotropin releasing hormone. That could be corticotropin releasing hormone, gonadotropin releasing hormone, growth hormone releasing hormone. But eventually these hormones are stimulated with the pituitary, and the pituitary gland then releases other types of hormones such as the antidiuretic hormone or the oxytocin, growth hormone, prolactin, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone. We have all kinds of hormones. So again, the hypothalamic pituitary axis is what drives our hormones to be released. The important characteristics about hormones is how they are modulated and then how are they suppressed. So we normally talk about feedback loops in order to discuss that. We have positive feedback loops and negative feedback loops. The first one we'll discuss right now is a negative feedback loop. And the example that we'll use today is the thyroid hormone. So what happens is that when said hormone levels fall, the stimulation starts the release of the hormones. So the body is constantly sensing these levels of our various hormones. And once the body realizes that this hormone is not circulating enough in the body, the hypothalamic pituitary axis is stimulated to produce the hormone, and it works on those target organs that help stimulate the release of those hormones as well. So once the hormone levels are elevated in the negative feedback loop, stimulation ends, and that helps to no longer secrete the hormone anymore. So again, we have thyrotropin releasing hormone. In our photo here, we see that cold temperature is a stimulus that triggers the brain to start stimulating the thyrotropin releasing hormone. Well, thyrotropin releasing hormone actually stimulates thyroid stimulating hormone, which helps to stimulate the thyroid hormone from the thyroid gland. So once that thyroid is stimulated from this outside stimulus, and again, it goes in a chain reaction here, it starts producing more thyroid hormone. So in this case, thyroid hormone helps to increase the temperature in the body. So once the body is satiated and satisfied with the temperature, and we no longer need this thyroid hormone, or there's enough of the thyroid hormone circulating to help the body regulate itself, you then see a stopping of this thyroid hormone to be released. So again, the body's inhibiting the release of thyroid hormone once this level is reached, and then stimulation thus stops. So this is a negative feedback loop. So again, the hormone levels are not at where they're supposed to be. Then the body stimulates the release of this hormone until an acceptable level is reached, and then at that acceptable level, inhibition occurs and it no longer stimulates that hormone. This is different from the positive feedback loop, where we see that there is a overstimulation, or the body has stimulated a hormone and then it continues to grow and grow and grow and grow until a said achievement is occurred. So we'll talk about this in terms of oxytocin and pregnancy. So the body knows that the pregnancy is happening. So at the onset of labor, normally you have uterine contractions that help the body to push the baby's head out. Well, oxytocin is stimulated to help with those uterine contractions and the stretching of the cervix. So this modulation will continue to happen, and more oxytocin will be stimulated, and the body will continue to make oxytocin until the baby is born. So again, there's that positive modulation. You have more oxytocin, more oxytocin, more oxytocin that is occurring until that oxytocin has reached a level where the baby has been pushed out of the woman, and then those levels then drop. So again, with a positive feedback loop, the hormone continues to increase until there's an interruption of the cycle, and in this case, that is the birthing of the baby. So the next thing we'll talk about is mediating cell-to-cell communication when it comes to hormones. Hormones can communicate with cells, and as we know, hormones have to communicate with cells, which eventually result in the tissues and the eventual organ being stimulated for a response. So we have different ways that cells communicate with those hormones. So the first one we'll talk about is the paracrine pathway, and this is where hormones are produced in the cell, secreted, and they act directly on nearby receptive cells. So this is a hormone to nearby cell interaction. We also have the autocrine pathway, which is the same as the paracrine pathway, with the exception that the receptive cells, or the cell that is secreting the hormone, is producing the hormone for itself. So it's producing the hormone for the hormone to eventually act on itself. So paracrine is where hormone goes to the nearby cell. Autocrine, self, it goes from the cell. The hormone is produced from the cell, and then it acts on itself. And then we have the endocrine pathway, where the hormone producing cell creates hormones that act on the capillaries or blood vessels. So the hormones are produced in the cell, and they are secreted and travel through blood vessels to act on distant cells. And they can act on the same cell, but we more so look at this as a reaction to distant cells. We have the synaptic pathway, where we have neurotransmitters, which are hormones that are produced within a neuron. So the difference is that a synaptic pathway is that they specifically have to be produced in a neuron. They are secreted, and they travel along the axons to synapses, where they are then released and taken up by a nearby neuron with appropriate receptors. So this is where you see the presynaptic pathway going to the postsynaptic pathway, as we discussed in our neural chapter. So again, these hormones have to be specifically produced in your synapses, in your neurons. And then we have the neuroendocrine pathway, where neurohormones travel along the axon to the synapses, but they go to the capillaries, and then they go to a distant cell to act on them. So this is a hormone from a neuron acting on an actual capillary. So again, we have these various methodologies for the cells to communicate with each other, and we do see these overlap and passage with these different types of pathways. This is just a reminder slide to make sure you define the following major hormones in the body. I want you to review antidiuretic hormone, epinephrine, norepinephrine, glucagon, cortisol, growth hormone releasing hormone, insulin, melatonin, aldosterone, oxytocin, thyroid stimulating hormone, and thyroid hormone. Make sure you look at those on table 13.1 in your textbook. This information is just regarding your stress response, and just know that your stress responds in several different ways. You have the actual physical reaction, which is the stress response to harmful forces or stressors. You have your neurological response, which happens in your brain, and this is internal activity. So that involves your autonomic cerebral cortex, limbic system, the thalamus, hypothalamus, and reticular activating system. And then you have the actual hormones that are associated with stress. Again, these are your stress hormones. So you'll see this a lot with cortisol, ACTH, corticotropin releasing hormone, and all of your catecholamines, which is epinephrine, norepinephrine, and dopamine. So next we'll talk about the different alterations in hormone function. We have 5 that we'll discuss. You can have impairment of the actual endocrine gland. You can have lack, or you can have excessive hormone synthesis, which will cause hyper or hypo alterations. You can have impaired receptor binding, so those hormones are not getting to the receptors that they need to in order to have the effect on the body that they need to. You can have impaired feedback mechanisms, and that's talking about your positive and negative feedback mechanisms. or you can have impaired cell response to hormones. So the hormones actually reach the cell, but the cells do not respond to the hormone. So now we'll have general manifestations of altered hormone function, and we'll talk about this in terms of hypopituitarism and hyperpituitarism. So hypopituitarism is just what it says. It's the lack of either function of your pituitary gland, and you have a gradual onset when it's affected. You'll experience fatigue, weakness, sexual dysfunction, anorexia, growth impairment, dry skin, constipation, and cold intolerance. And think about this. This is the gland that has all of the hormones, or majority of your body's hormones, that are stimulated from it. So when your pituitary is affected, all of these effects, or these hormone clinical manifestations, they have to do with the effect of the actual hormone that it's impacting. For example, the thyroid, you'll have a cold intolerance because your thyroid is no longer able to stimulate a temperature response in the body. So you have a cold intolerance there, and so on and so forth. As far as hyperpituitarism, when you see hyperpituitarism, you now have an overstimulation of all of those hormones that the pituitary gland then secretes. And there is a wide range of manifestations, and it depends on which hormones are elevated. It's also good to know that not all hormones are elevated at the same time. Some are a little bit more elevated than others. So that's why with hyperpituitarism, you have to look at which hormone is most affected, and honestly, the signs and clinical manifestations that are presented as such. When we treat hormone functions, it depends on the cause in which hormone is actually elevated or not elevated. If we have hormone excesses, you want to remove the tumor secreting those hormones. It may be an actual endocrine gland that's secreting excess hormones, so you may remove part or all of the endocrine gland that's doing that, or you may take medications that block the effects of that hormone. If it relates to a hormone deficit, you may have medications that help stimulate or replace that hormone that is depleted. When you have diagnosing of your hormone function, you want to have a history and physical examination, and then you'll have laboratory panels that are pulled. Normally it's your serum and urinary hormone levels. You'll have hormone suppression and stimulation tests, and you'll also have electrolytes, glucose, and calcium levels that are also tested. They'll also look at imaging studies and also look at your genetic makeup as well. So here are our concepts for altered hormonal and metabolic function. We have SIADH syndrome of inappropriate antidiuretic hormone, diabetes insipidus, hyperthyroidism, hypothyroidism, Cushing syndrome, and Addison's disease. When discussing antidiuretic hormone, or the syndrome of inappropriate antidiuretic hormone, is first you should know what the function of antidiuretic hormone is. So the secretion of antidiuretic hormone helps to prevent you from urinating or prevent fluid release. So antidiuretic hormone, when you have an antidiuretic, you have an anti-release of fluid hormone, is basically what that's saying. So with syndrome of inappropriate antidiuretic hormone, you have excess production and release of antidiuretic hormone. And most oftentimes it's caused by a tumor secreting ectopic antidiuretic hormone. So this tumor is secreting more ADH in the body, and the body's responding to it as if it's coming naturally from the pituitary. That antidiuretic promotes water retention. So again, you are retaining water. So that water accumulates in the cells, which alters function. So you'll see a lot of hypovolemia in individuals with syndrome of inappropriate diuretic hormone. Your sodium levels are diluted, and you may even see the result of hypotonic hyponatremia as a result. So that means that your sodium levels are hypotonic in nature, so there's dilution. As far as your clinical manifestations, you'll see decreased urine output because all of your urine is being retained. You have severity of symptoms, and that depends on your serum sodium levels. So you may see clinical manifestations of hyponatremia, which include nausea, vomiting, headache, anorexia, irritability, disorientation, cramps, weakness. In severe cases, you'll see psychosis, gait disturbances, comas, and seizures. As far as your diagnostic criteria, you do have to have your serum panels and your metabolic panels pulled to look at your sodium levels. So you'll be diagnosed with hyponatremia, and that's a serum sodium level way less than 135 milliequivalents per liter. You'll be diagnosed with hypotonicity, and that's your plasma osmolality, which is less than 280. You'll have decreased urine volume. You have highly concentrated urine with a high sodium content, or the absence of renal, adrenal, or thyroid abnormalities. As far as your treatment, you want to remove the cause. So if it's a tumor, then that tumor should be removed. You want to restrict water intake. You want to treat with isotonic or hypertonic IV fluid placement because your sodium levels have depleted. So you want to replace with something that will help replace the sodium. And then you may have pharmacological treatment, particularly maybe diuretics, to help clear out that fluid from you. So here we have the opposite of syndrome of inappropriate antidiuretic hormone. And it's interesting because this says diabetes insipidus, but this hormone that is affected has everything to do with antidiuretic hormone. So in this case, with diabetes insipidus, you have insufficient antidiuretic hormone. So this means that you are unable to concentrate or retain water. So you are dry. So diabetes insipidus, a way that I remember this is diabetes is dry, D for dry. And again, you do not have enough antidiuretic hormone to circulate in the body. And some of the causes are insufficient ADH production or secretion through the pituitary gland. You have inadequate kidney response to ADH, or you have water intoxication. Some of those clinical manifestations include excessive thirst because you're dry, dehydration because you're dry. You have shock because you don't have any fluid to circulate. There's a hypovolemic state here. And then you have death. You may see polyuria as well. So do not get this confused with diabetes mellitus. This has nothing to do with insulin or glucose. This has everything to do with antidiuretic hormone and the insufficiency thereof. So as far as your diagnostic criteria, you have to have a history and physical examination. And normally they do your laboratory tests. So they'll pull your serum solute concentration. They'll look at your metabolic panels, of course. You'll look at ADH levels, urine specific gravity, and your urine osmolality. You may even see hypernatremia because these individuals are dry. So salt does essentially make you dry, especially if you are not retaining water well. So you have more of a solute in the body than a solvent. So you may see hypernatremia in individuals like this as well. As far as the treatment, you want to treat the cause. You want to hydrate appropriately with a hypotonic solution or isotonic solution, depending on the severity of the diabetes insipidus. And you want to also treat with desmopressin. This is an analog of vasopressin, which acts as an antidiuretic. So you want to replace the insufficient ADH. So again, desmopressin is the same as vasopressin, which is like giving someone antidiuretic hormone. So that is an antidiuretic. Here we have hyperthyroidism, and it's just what it says. It's the excessive thyroid hormone, and it can be caused due to excess stimulation of the thyroid gland. Maybe that thyroid is diseased, and sometimes with disease, it produces that extra thyroid stimulating hormone. One of the more common forms of hyperthyroidism is called Graves' disease, and this is an autoimmune disorder. And there is no known etiology. If I were to give it one, it's called idiopathic in its etiology because it's unknown, but it is considered an autoimmune disorder. We have that immunoglobulin or that antibody IgG that binds to thyroid stimulating receptors on thyrocytes, and this ultimately causes a overproduction or overstimulation of that thyroid gland. And again, when we see these antibodies, it's with the inflammation response and the autoimmune response. So with clinical manifestations, you'll see weight loss. You may see a goiter, which is that large lump on the neck area. You may see agitation and restlessness, sweating, because individuals with hyperthyroidism, they're hot, they're heated. One thing that thyroid hormone does is that it helps regulate body temperature. So in excess of something that helps regulate body temperature, you do see this sweating and heat intolerance. You'll see diarrhea, tachycardia, palpitations, tremors, fine hair, oily skin. You'll see individuals with the irregular menstrual cycle, weakness, and exophthalmos, which is the bulging of the eyeballs. As far as your diagnostic criteria, of course, you have to have history and physical examination. And most oftentimes, they're pulling your thyroid stimulating hormone levels and your T3 and T4, which are your thyroid level hormones. They'll also look at your free thyroxine level and increase uptake of radioactive iodine by the thyroid gland to see if there's a diagnosis. So there's radioactive iodine that the gland would take up, and it will confirm the overactivity of this thyroid gland. As far as pharmacological treatment, you want medications that block thyroid hormone, stimulating hormone, and thyroid hormone production. You want to avoid oral thyroid hormone replacement. Too much of it, at least, because the point is to remove the thyroid. So if you replace too much, then you'll have the same signs and symptoms. But the treatment, they may remove or destroy that thyroid, so you can't live necessarily without your thyroid or something that's stimulating the functions of the thyroid. So that's where you'll see some thyroid hormone replacement, and that's why you see it on this slide. But again, too much of that would cause the same clinical manifestations and would technically be detrimental. So they have to test it and see which levels of thyroid hormone replacement work for each individual. So destruction can be completed with radioactive iodine, and you can actually remove part or all of the thyroid gland to help prevent thyroidism. But just remember, if they remove all or part of the gland, there is a little bit of replacement therapy that has to happen in order to keep the body maintained and balanced. This is an example of Graves' disease, and the pharmacological treatment is, again, a medication that blocks that thyroid hormone, or they will have to replace the thyroid hormone a little bit with replacement therapy. What I really want you to pay attention to is the exophthalmos with this individual's picture. As you can see, the eyes are bulging from the sockets. So with Graves' disease, this is a very significant clinical picture of this. And again, it is treated by the destruction or part or all of the gland, or with radioactive iodine or surgical removal. But as you can see, this individual, they have not had their thyroid removed yet, and you can kind of see a bulge in this individual's neck, and that's the goiter that we speak of. That's the bulge in the neck. So with this individual, this is kind of a classic clinical picture of Graves' disease and hyperthyroidism. Next, we'll talk about hypothyroidism, and this is a congenital disease, or it can be acquired as a deficiency of thyroid hormones. So individuals that had hyperthyroidism can eventually develop hypothyroidism because that gland has been removed, or it has been partially removed, and they're not getting their replacement therapy as such. But if it's congenital in effect, it's basically because you have a lack of thyroid gland development from an early age. So that results in the deficient synthesis of thyroid hormone. Again, you can have this condition with the destruction of the thyroid gland through radioactive synthesis or removal surgically. And then you can have this with impaired secretion of thyroid stimulating hormone. So there are definitely multiple and a multifactorial etiology with this. You can see this with autoimmunity or genetic defects to the gland, and then there may be an iodine deficiency. As far as your clinical manifestations, you'll see fatigue, lethargy, weakness, weight gain, cold intolerance, constipation, dry skin, coarse hair, impaired reproduction, impaired memory. You'll see a goiter or mixed edema. As far as diagnostic criteria, You have to have a history and physical examination, of course. And then you have laboratory studies such as TSH. They'll look at your thyroid levels, T3 and T4, total T3 and total T4 uptake, your antibodies, and your antithyroid globulin. As far as treatment, you have to have lifelong thyroid hormonal replacement therapy in order to prevent hypothyroidism. So we have Cushing's syndrome, and Cushing's syndrome is considered excess glucocorticoids secreted from the adrenal cortex. This is your cortisol levels, and it does affect your metabolic function and stress response. Cortisol is directly related to your stress response. It can also be related to your inflammatory and immune response. The cause is long-term administration of glucocorticosteroids, so that's why when we give you something like prednisone, they give it to you for a short period of time, and if you do have long-term therapy, they have to taper you down from those types of steroids because it could cause an adverse effect such as Cushing's syndrome. You have tumors of the pituitary, adrenals, or you may have even distant sites or ectopic hormone secretions. And again, when we talk about ectopic hormone secretion, that's coming from a tumor cell that's mimicking the functions of other cells, and it's causing the overstimulation or understimulation of this hormone. You have clinical manifestations, and that can result in your metabolic alterations, metabolic acidosis, and metabolic alkalosis. You can have trunk obesity, moon face, upper back issues, glucose intolerance. You may have the suppression of the inflammatory response because um, that's what cortisol and steroids do. They suppress the inflammatory response. So if you have an over excess of these glucocorticosteroids, you have a over suppression of your inflammatory and your immune response. You may see behavioral changes, and you may also see an impaired stress response because cortisol is directly related to your stress response. As far as diagnostic criteria, they may look at your urine, do a 24-hour urine sample and look at the cortisol levels in that afterwards. They may even do imaging studies to detect tumors. And again, tumors are tall tale signs of producing ectopic hormone secretions. As far as treatment, you want to remove the cause of excess cortisol secretion. So if that is a tumor, that tumor should be removed. You want to gradually taper glucocorticosteroids, and you want to surgically or maybe even use chemotherapy or radiation to help remove those tumors. But regardless, those ectopic hormone secretions, that would be the cause. So that's what you would have to remove in order to treat this well. Last but not least, we'll talk about Addison's disease, and this is an autoimmune destruction of the adrenal cortex. So normally your adrenal cortex or the adrenal gland produces glucocorticosteroids, that cortisol, mineral corticosteroids, that's that aldosterone, or your androgens, which eventually result in testosterone. So those levels increase to stimulate the secretion of the hormones from the adrenal gland. So when there's an adverse effect with this, again, you can't produce these hormones anymore. So what results is darker skin, pigmentation. You may see glucocorticoid deficiency, and normally glucocorticosteroids are associated with glucose levels. So if you have a deficiency of these steroids, you may see hypoglycemia and the effects of hypoglycemia, which is weakness and poor stress response, anorexia, nausea, vomiting, weight loss, personality changes. If you lose too much, you may even see individuals go into a coma. You see mineral corticosteroid deficiency, so you'll see dehydration, hyponatremia, hyperkalemia, hypotension, weakness, fatigue, and shock. As far as your diagnostic criteria, you have your history and physical examination. You may be diagnosed with hyponatremia or hyperkalemia, and they will pull your serum corticosteroid levels, and if they remain depressed after ACH administration, because ACTH is supposed to stimulate the secretion of those hormones. So if they remain depressed after this, after you're giving this, then they know that you have some sort of Addison's disease. As far as treatment, you want to do fluid replacement, particularly with D5 if it's related to glucocorticoid deficiency. You want to do pharmacologic treatment. They may give you hydrocortisone. They may give you oral steroids, again, that's prednisone. They may encourage dietary changes, and you may have to increase your sodium intake because your sodium is being lost due to the lack of stimulation of these hormones. So again, this is a full circle here. You'll see that these diseases with your hormones, they do manifest with electrolyte imbalances and fluid electrolyte imbalances, and even can turn into acid-base imbalances if not left treated. So you have to look at these and monitor them accordingly. Thank you for watching, and just make sure you complete all of the following. Make sure you look at your chapter and do your guided learning questions. Complete your disease cards. Make sure you do your case studies and activities. Make sure you review your pathophysiology, clinical manifestations, diagnostics, treatment, and application. Make sure you quiz yourself and others and answer the questions in the back of the textbook. And if you still don't understand, feel free to ask questions. Thank you, and I look forward to seeing you in class.